Shall I make a start then? Welcome everybody to this fantastic IPC Partners and IPS Partnership Journal Club. I always look forward to doing these. It's always great to be a part of them, but also to listen in. And it's great to see where we've got steady numbers coming in. I think we've gone around about 200 to 300 people hopefully going to join live. So that's fantastic. And it's great to be here talking about behaviour change as well, which is, I think, so critical to a lot of our work. And I'm glad and very grateful to be joined by some of my colleagues. So I'm Kerry Holden. I'm the Deputy Director of Infection Prevention at Gloucestershire Hospitals, but also the Vice President of the Infection Prevention Society. And I have some amazing colleagues with me who hopefully will introduce themselves now. Heather, would you like to introduce yourself?
Hello everyone, thank you all for joining us. I am the current editor of the Journal of Infection Prevention and Control for one more week, when I hand over to Professor Jean-Yves Maillard, who I'm sure is going to take the journal from strength to strength. And I hope that those of you who are joining us today and who have research interests and implementation stories to tell would actually think about publishing those in the Journal of Infection Prevention, because it helps us all learn. It ensures that we are involved in what's happening in practice. And I think we can all appreciate some of the issues that face clinicians going forward, particularly around implementing research. I think if we do that, if we publish our work, if we publish and share our learning, then we can actually be much more effective in making change happen, which is the title of our journal club today. And we've selected two papers, one slightly theoretical and the other much more practical, to try and underpin those particular concepts, if you like, about how can we learn from behaviour, and then also how can we use that learning to influence practice in the clinical setting. So I think if we could just remind people that if you have questions after Jon and Phil have actually presented the papers, if you could pop those in the Q&A, and if you have comments, if you pop those into the chat, it makes it a little bit easier for us to try and sort things out. But Kerry and I will be keeping our eyes on that as we go ahead. So Jon.
Yeah, thanks, Heather, and hi, Kerry. Hi, Phil. Great to be with you all this afternoon. My name's Jon. I'm the Director of IPC at Guy's and St Thomas's in London as my day job, and co-founded IPC Partners last year.
I think that just leaves me. Hi, everybody. I'm Phil. I'm a research fellow at Brighton and Sussex Medical School, where I'm leading a programme of research around sustainability and IPC, and looking at the safe reuse of medical devices and products. And yeah, really excited to be here in partnership with the IPS and talk about one of the papers that I looked at from JIP earlier.
And I think, Heather, you kindly alluded to your sort of last week as editor of the journal, and I think it would be remiss of me not to say how thankful we all are for all of your amazing hard work, and express really the heartfelt thanks of the whole of the Infection Prevention Society for your remarkable work as editor of the Journal of Infection Prevention, and the enthusiasm, expertise, and the tireless efforts, which I know is probably some sleepless nights, I suspect, as well, have really shaped the journal into a really esteemed platform for knowledge and innovation, and a real fantastic resource for infection preventionists. So we are really grateful for the time and the care and your leadership in as editor, and we do wish you every success in the for future endeavours, but probably know that you can't quite get away from the IPS once you're part of the family. So I suspect you won't be going too far away, and I'm very glad of it.
No, I think it has very long tentacles that tend not to let you go.
Indeed.
Thank you for those kind words.
No, you're most welcome. And I'm sure everybody's feeling the slight pains. We were just chatting, weren't we, about our pains of our life at the moment. It's probably flu for most of us. So I'm hoping all of you guys are staying safe, staying well, and able to kind of, hopefully some of the insights from today will give you some even more food for thought about how we might tackle future winters, even if not the current one that we're in. But how is it for you guys on the floor, I guess, Jon, and some of the things that you're tackling at the moment?
Well, I've just got back from maternity leave this week, so I've been out of the loop for a while, which has been lovely in all sorts of ways. So I've been hit by a bit of a splurge of respiratory infection in our emergency department, which is always a challenge.
Yeah, indeed. Absolutely. And I think it goes to, I think we were chatting, weren't we? It goes to a little bit of the challenges we've got generally across health services at the moment. I know we're certainly feeling the impact of pressured ED and lots of flow and capacity challenges, making it quite difficult to make quite difficult decisions, I think, at times, where our hands are tied behind our back trying to make the best IPC decisions for our patients and for our staff to keep them safe.
Yeah, I think that these two papers actually a really good way of maybe looking at things a little bit differently as well. I think the one that I'll talk about later, thinking about a new way of IPC education, is probably a really interesting way to think about how we evolve and how we kind of keep up with current challenges around staffing, admission pressure, winter pressure, flu, masking, and all the rest of it.
I think one of the things that's so interesting is that often we can become very sort of bound up in the moment, and sometimes trying something different, so making change happen, can really free us a little bit. We sometimes think, well, oh God, it's more work to do, but also it can be more work that has a good outcome, which makes us feel more positive about what we're doing in practice, and can, success can breed success in some instances where you're facing real challenges resource-wise.
Absolutely.
Yeah, and I think if you look at the prospect of making change happen, particularly on an organizational level, it's never been more important, because if we can show, let's take flu in the ED as an example, if we can find a way to somehow improve flow and reduce infection risk, then that brings pretty big and important benefits to the organization.
Absolutely.
Okay, so
yeah.
Shall we move into our papers? And I think first up,
nice route in, I think.
Yeah, first up is Jon Otter, who's going to discuss the use of behaviour change theory, I think.
Okay, thanks, Heather. Let's make a start. So, just a little bit of background on what these journal clubs are all about. We always try and look at a topical paper, two in this case, double whammy, to try and generate discussion. Do please get your questions into the Q&A box. The sooner you get them in, the more chance there is that we'll get to them in the discussion. We're interested in providing opportunities for CPD for ourselves and for you. We want to exercise critical thinking skills, not just to take things at face value, but to look into the detail of what's being said, to build confidence for independent research and study as well, so that you can go away and pick up a paper and feel confident in kind of pulling the essence out of it, pulling the meaning out, to try and generate a network of enthusiasts and have a bit of fun as well. As ever, this event will be recorded and made live online after the event. So the topic for today, the use of behaviour change theory for infection prevention and control practices in healthcare settings, a scoping review. Nobody really likes theory, do they? And like driving theory, music theory, it's something that we tend to avoid in life, but this is really important stuff. Anybody ever felt like this before? This is a schematic of a path to behaviour change. I can think of several different kind of local level organizational changes that I've been through that have looked quite a lot like this, actually, with hurdles and traps and blind spots and oncoming vehicles and all the rest of it. That just makes life hard. So achieving behavior change is something that is incredibly important to IPC. You could even begin to make a case that behavior change is IPC, because if we think about all of the sort of foundational interventions that we may or may not make, hand hygiene, screening and isolation, environmental hygiene, antimicrobial stewardship, all of those have a huge component of human behavior. So if we can find a way to meaningfully affect behavior change, then we're likely to be left with an effective IPC service. So why did I choose this paper? Well, I know behavior change is important, but personally, I lack the detailed understanding of the science behind it. I'm not a behavior change scientist, so I feel like I need a bit of help from behavior change scientists to make sense of all this. Related to that, there's many different theories out there of behavior change, and it's not often clear to me which one would be the most useful. So just by way of background then, before we get to the details of this scoping review, when you break it down, there are some fundamental determinants of human behavior, which are, I know, faintly depressingly similar, regardless of which behavior we're looking at, regardless of which sector we're working in. These theories of behavior change work, and they explain the way that human beings operate. So in that sense, there's a simplicity about the way that humans behave. I mean, it's far from simple, but I hope you understand what I'm trying to say. And these are described in several interrelated theories of behavior change. The reality is interventions may fail. A good intervention may fail because it has overlooked the behavioral determinants that will influence whether or not it actually works. And behavior change theories offer a structured approach to help us understand how these determinants influence behavior. So there's a number of different commonly used theories of behavior change. The really lovely, simple COM-B, where we need to think about the capability, the motivation, and the opportunity to affect behavior. This is something I've actually used before, back in the early part of the pandemic when things were going crazy with PPE use. And you'll remember people were wearing all layers of PPE they didn't need, hats and overcoats and scarves and all the rest of it. And it was our job to try and coach people to make better decisions about PPE. We had a behavior change scientist seconded to the IPC team at Imperial, Darshan Patel. If you're listening, Darshan, I hope you're well. And he was brilliant in explaining the COM-B behavior change theory and how it could apply to us and how we could use it to develop an optimal PPE helper program, as we called it. And it worked. We improved knowledge and we improved practice related to PPE. Now, the COM-B framework maps one-to-one pretty much on the theoretical domain framework, the TDF, which is a bit more detailed. And then another theory which is related to these two, but others as well, is the behavior change wheel that incorporates elements of 19 different theories to try and give us a visual schematic of how we can affect behavior change. And you can see COM-B in the middle there. So to the paper itself, then, this was a scoping review of the literature questioning how can behavior change theories been applied to IPC practice in healthcare settings. And they were particularly interested in the TDF, COM-B and BCW, but any change in IPC practice was included. And this is what they found. I was surprised by this. Only 11 articles that were identified in their searches met the inclusion criteria. So there was a big chunk of literature that was identified in the searches but didn't meet the inclusion criteria. And we'll come on to that in a minute, because 11 doesn't feel quite right. I've got a sense there's more relevant research out there, and perhaps a tweaking of the inclusion exclusion criteria may have been helpful here. Nonetheless, the studies covered hand hygiene, 7 of them, antimicrobial stewardship 3, and MRSA screening 1. They identified 3 domains that were commonly came up as reasons where these behavioral determinants were being barriers to effective behavior change in these areas. Beliefs about consequences. So this is sort of fundamental to IPC. The problem we have is that the poor behavior is divorced from the impact. If you miss a hand hygiene opportunity, cause an HCAI, patient even dies down the line, you never link that missed hand hygiene opportunity to the healthcare associated infection that resulted in the death of the patient. So we've got that separation of the action from the consequence, and that's really unhelpful for us in terms of behavior. Environmental context and resources often come up. People say, how can you expect me to screen the patients when you don't give me enough swabs? You know, things as simple as that, or how can you expect me to change antibiotic usage to be optimal when the right agents aren't available to me? And social professional role and identity often comes up, thinking about differences in professional groups and how they behave. Most of the studies were looking at barriers and facilitators, which is important, rather than designing interventions. So these behaviour change theories can be used to either understand barriers and facilitators, but they can also be used to design and also evaluate the impact of interventions at the business end of things. So only 3 of the studies developed tools or interventions that were informed by behaviour theory. There was one nice study showing the benefit of taking this approach. So they did a questionnaire, and they used 2 sets of questions. One set was informed by a behaviour change theory, and one was not. It was just informed by the literature. And they evaluated the differential impact of those 2 different sets of questions on the sort of information they got out. And they found that the questions that were informed by behaviour change theory identified some of this sort of subconscious barriers to hand hygiene performance, whereas the questions informed by the literature didn't identify those. They only identified the conscious barriers. So it was a nice example for me of where behaviour change theory can really enhance the methodology of a qualitative piece. So thinking about strengths and limitations, this was a comprehensive mapping of how behaviour change theory has been applied to IPC, which is helpful and highlights those 3 key domains influencing compliance with some practical tips for intervention design. In terms of limitations, I've mentioned it already, only 11 articles covering 3 interventions from 2 countries. And that feels like a small body of literature. Perhaps that's all there is, but maybe there's more out there. It was a scoping rather than a systematic review, which has benefits, but also limitations. There was a natural reliance on self-reporting of compliance in some studies, risking bias, which I think is fairly inherent. And as I mentioned before, a few examples of theory-informed interventions. So I think that's sort of the next step with this body of research. So how can we incorporate these theories into our practice? Should our audits include behavioural determinants alongside compliance metrics? So, for example, when we're doing a hand hygiene audit, we might not only say our compliance rate was 25%, but we might begin to say 20% of our staff didn't undertake hand hygiene because there wasn't any gel available, or other behavioural determinants. Perhaps that's not a good example, but I hope you get the point. What strategies can overcome the environmental and social barriers identified in the review, and how can we think about tailoring our interventions towards the professional groups that came through as a common barrier to effective implementation? So finally then, before we get to your questions, what does this mean for IPC? Unsurprisingly underscores the importance of moving beyond education and policy and audit to thinking about behavioural aspects of IPC compliance. What's driving performance? We should use these frameworks. They're helpful to help identify barriers and facilitators. We should also use them to design our interventions and target those key domains that come up often, and think about whether we can generate scalable tools to address behavioural influences, and finally think about next steps and advocating for research that is informed by these behaviour change theories in order to optimise the impact of the subsequent research practice. So Heather, Kerry, we're back to you. Let's see what questions we have.
Thank you, John. I think there is a question in the chat, but I think, oh, have we lost Heather? So thank you for that. That was really insightful, and I think actually, oh, have we got Heather back?
I am here.
Oh, there we go, brilliant. Really insightful, and I think the questions that you posed to us are probably some good questions and reflections. If we don't have a massive amounts in the chat, might be quite good to discuss through. But Sheila has put in the chat, do staff use barriers as an excuse to not use the correct practice? Which is an interesting reflection. I don't know if that's her experience or not. What are people's thoughts on that?
Yeah, I mean, I think that yes, I'm sure that's true. Any excuse will be put up to avoid doing the right thing or complying with things, particularly when they're hard or inconvenient. But I think this probably comes back to the sort of system fault versus individual fault. When you're looking at when things have gone wrong, I think it's very easy to point the finger at an individual and say, "Oh, you're just making an excuse," whereas actually it's a system problem. So most of the time, I think we should be looking at the system level to implement these sorts of behaviour change, rather than thinking about individual practitioners who might be taking advantage where they shouldn't.
Definitely supportive of that, and I have to say I've definitely seen a hopefully in the sort of in the NHS in England, particularly the move from root cause analysis, traditional single points, what's causing this problem, towards more of a PSERF approach, which is looking at the sort of patient safety incident framework, and then that really brings in the SEEPS model, and I don't know if people are familiar with that, which is the system engineering initiative for patient safety, and that really looks at the system, it looks at the people, it looks at the training, the environment, external factors like workforce, and that really helps us, I think, to understand, particularly when we're looking at potentially if there's an incident or a patient safety incident or outbreaks, it gives us a much wider understanding about some of those barriers that aren't sort of, you're just not doing it and you're not educated and you're not trained, which is often tends to be our bit of our default, isn't it? And I have to say, it's now, I think the digital solutions also become a bit of the default solution. Intervention is make it digital and educate, and we know sometimes the kind of hierarchy of evidence suggests really that those sorts of interventions, particularly lecture-based education, aren't really the most supportive of changing behaviours. But Heather, I don't know if you've got a reflection on that as well.
Yeah, I suppose I think so. I think the behaviour change wheel actually helps us with that. I think in many ways it takes a lot of those sort of contextual elements and looks at how they might feed into informing our behaviour change sort of interventions. I mean, I think if you take it on an individual level, there are always reasons why people are doing things, if you like, finding workarounds to things rather than necessarily doing them in the right way all the time. But I do think that I think the SEEPS model is really helpful, because what it does take is it takes this sort of systemic view, but it also feeds in those approaches which are related to individual behaviour. And I think we have to understand the reasons why people behave, and it's often to do with beliefs that may be changed if we use the right approaches. And so I think it's really quite important that we take that more holistic view of behaviour change, and trying to think about how can we make the system easier for people to negotiate, but also then how can we target individual behaviours that we understand. I mean, much of the work I've done in glove use is trying to understand why people do the things they do, and actually talking to them about, well, I've observed this, why did you do it that way, what's your reasoning? And I think that's often time consuming, but really very important when we're looking at how we want to change behaviour.
Just to link in, sorry, Kerry, just because I think it's a salient point, is that I think that the paper that I'm going to talk about talks about how you can actually deliver this in practice. Now, it's extremely kind of resource heavy, the ability to have somebody from an IPC perspective deliver education during a ward round. But I think that the thing that I'll unlock in the discussion is that builds confidence, it builds relationships, and it helps cut down those barriers when you're making the kind of education specific to what's going on in that person's ward and in their patient population. So it's just about another way to overcome those barriers potentially.
Yeah, and there's some interesting reflections, I think, in the chat that sort of summarise some of those challenges of why it might not be easy to get ask people to do the right thing, or at least we ask them what want them to do. So yeah, I think it was Alta was mentioned in South Africa, particularly post-pandemic, high workload is often reflected as a challenge. So that I think they're trying to support integrating IPC into everyday practice and every action, so it lightens the load and hopefully the attitude. But if the attitude seems to be that it's the last straw, so interesting whether that's a unique experience. And then she reflects that bare blue elbows is a personal choice and not a system problem. But again, I think that reflects to what Heather you were saying about understanding what motivates people to do the things that we ask them to do, and why they might not. So yeah, interesting.
There's an interesting question from Faye Pinker in the Q&As. Do you think negative behaviour around IPC is because of training, the way we train our students? Are we using the wrong approach? Do we need to make our education more interactive and engaging? I don't know if anyone has any comments on that. I'm an educationalist, so I do have a perspective, but I'll keep quiet for a little while.
Yeah, I think the way that we've trained our practitioners has not been informed by behaviour change theory. It's something that comes to practitioners later in life as they go through their experience, right? Of the workplace. So I think it would be really incredibly valuable for us to begin to introduce the idea of behaviour change theory and underline the importance of behaviour change in general, as we're educating our practitioners. But Phil, Kerry, appreciate your views as well.
Yeah, no, definitely agree. I think that kind of classroom e-learning kind of approach to education is somewhat falling short. I think our experiences certainly as a simulation and those types of environments where you can test your kind of theory and practice has always gone down particularly well. And interesting, I remember listening to a talk at the conference and they looked at sort of the hierarchy of education and they said one of the best ways is to get other people to teach what you've taught to other people. So you're sharing that information and how you've digested it to others. And I thought actually that's a really nice way. And actually, how do we use our link practitioners or champions to kind of share that message on and get that kind of that model of train other people with what you've learned to consolidate that learning a bit more. But Heather, you're the educationalist on the call.
Yeah, so I mean, if I come from the perspective as sort of a an educator, I think one of the things with infection prevention and control education, particularly in undergraduate students, if we talk about how we prepare our registered nurses, midwives, other healthcare professionals, is that regulators tend to think in silos. And so instead of thinking of IPC as something which is fundamental, and I love this word of fundamental, it's a fundamental part of how we care for people. It's really important to maintaining their safety. And I think that developing approaches that integrate infection prevention and control as part of how people think about the care they deliver is absolutely the core and the crux of the issue. And I think advances in simulation, the use of simulation so students can learn in safe spaces, so they can make mistakes and you can talk about what it is they've done and why they did it that way, I think are really helpful ways. And I do think they're becoming more frequent and part of mainstream undergraduate education. But we also use that in our MSc for infection prevention and control practitioners. We use simulated approaches and get them to look at actually what they're asking people to do and is it possible. It sort of has that sort of critical thinking component to it that Jon mentioned earlier about if we're asking people to do things that are virtually impossible because of a system that exists, we're setting them up to fail. So I think we're making advances in education. I'm not saying it's right, 100% right at the moment, but we're getting there, I think.
Phil,
I was just going to, yeah, thanks. I was just going to jump in on, a couple of things there around simulation, but also I feel like this discussion's taking the thunder out of my talk. But we'll come to that. One of the best examples of simulation I've seen, kind of on a local IPC level, is the Marion Reed development course, which is run in the West Midlands by the IPS, and simulation is a huge part of that induction process or that course for people who are new to IP. So it wraps around the concept of theory, but also then being able to learn kind of on the job, I guess. And they set up some brilliant kind of simulations where you've got a patient in an isolation room or you've got a patient having kind of IV therapy, and they're there to spot what the challenges are and they can learn in that kind of simulation. So I think just building on what Heather had said, I think that being able to learn on the job and apply it practically and have a discussion in a safe space is a really positive way to kind of instill those thought process and behaviours.
And I guess you're the only reflection whilst we're talking about education, and it was something we picked up in the Southwest and where I work, is that do we actually train our infection preventionists to understand how to apply behaviour change, and are we set up with the tools to be able to go out and do it? And I wonder whether that might be potentially why some of the publications are missing, because we're not articulating the full theory and the science through some of the interventions we're doing? And is it, actually, is there an opportunity to be ensuring that as preventionists, we're also trained up to be behavioural scientists in a sense, or at least be able to apply it to our practice? So we did a big piece of we're doing some research at the moment, particularly around behaviour change around moment one for hand hygiene. But what part of that piece of work was also to just provide training and some skills to be able to actually go away and do it. And then we're hoping at the end of this research not only to have some insights around hand hygiene behaviours, but also to how to people to apply behaviour science in a really kind of in an easy way to do it, rather than feeling like this, well, this is not for me to do. Some practical tips about how you apply this to different situations and different scenarios. So hopefully still to come. We're just waiting for ethics approval, but hopefully some research might even get published in the in our journal, hopefully.
Okay, should we move on? I think there are some questions that maybe we can use for after Phil's presentation in the comments and chat. So Phil, would you like to take us off on our second paper so we don't steal all your thunder?
Thanks, Heather. There's a really interesting discussion and lots of comments to try and get back to later on. So yeah, I'm going to be talking about this paper published in CHIP, which is about ward rounds by infection prevention control teams to deliver education and enhance knowledge to clinical staff. And I think we've kind of touched upon some of the themes that I'm going to be talking about. And just reading the kind of abstract of this paper, it got me thinking about how we deliver infection prevention and control training. I've delivered it, I've received it, and I think that there are some challenges in the way that it's currently set up. A lot of the time, Martin Kiernan's expression from a podcast I listened to on this paper earlier actually is that people are brought kicking and screaming towards mandatory training, and the time that we have to deliver IPC training within that mandatory training, I personally think is becoming less and less. And there's studies out there that show, people who are receiving mandatory training, they often find it difficult or frustrating, and it becomes classroom-led, not practical. There are kind of some challenges, I think, and I think a refresh about the way that we deliver IPC training is why I was so interested to read this paper, because, ward rounds going on all the time. I guess my first instinct was that could be quite resource heavy to be able to deliver that. Having an IPC specialist or nurse supporting every ward round can't happen, but could it happen in targeted areas? So I was really interested to read the paper and try and overcome some of this challenge that we have around the way that we provide IPC training. Personally, I'm really passionate about IPC education. That's one of the reasons why I started the Journal Club with Jon, was to be able to share ideas and research around education. And I love this term about how we put IPC policy into practice, because as IPC practitioners, we often write lengthy policies about how we isolate patients or how we perform hand hygiene or around ventilation or new builds. It's really broad and diverse. But the big challenge is how we get our frontline staff to take it up. And the behaviour stuff that Jon talked about was a really nice segue into this kind of paper. I'm also really interested on how we can look at additional ways to teach our workforce. So the idea of moving away from classroom or e-learning, ward rounds to me sounded like a really excellent opportunity to try and achieve that. I think we've seen reductions, as I've already alluded to, in the amount of time we have to teach our healthcare professionals IPC. I think if I had a unlimited training resource and budget to be able to train staff in a hospital, I'd probably want a whole week to talk to them about IPC, to be honest. That's to get them to the level that I would like to have, which obviously isn't feasible. I also thought the ward rounds would be a really interesting way to help tailor the messaging, because you're able to potentially building up over a period of time. And I was also really interested to see if the paper talked about any building of relationships and to see if this had an impact on the training as well, because you're having that training, that conversation, in the patient environment, surrounded by patients and other healthcare professionals, and ability to maybe have a two-way conversation. So lots of reasons why I chose the paper. So this was done at Great Ormond Street. They describe their hospital as a high dependency cardiac unit within a paediatric tertiary care hospital, sorry. And what it was focusing on really within the intervention as part of the IPC support in the ward rounds was focusing on the knowledge and confidence in managing patients from an IPC perspective, specifically with the nurse in charge. And I think in the paper they talk about nurses in charge around the band 6 level from an NHS perspective, and people who are kind of in charge at that time and point. They used a mixed methods study, so they were collecting both quantitative and qualitative data, which I thought was a real strength because it's always good to have the two perspectives. They were using pre and post intervention questionnaires and using a Likert scale, and then there was some reflection and thematic analysis that the IPC educator did at the end of every ward round as well. One of the reasons why I love doing these journal clubs is that I get the opportunity to go away and learn, and I feel like I've learned a lot around behavioural models throughout the journal clubs that we've been doing via IPC Partners. So this is something I'd never heard of, so I had to go and do a little bit of research, but they use something called a spiral model, which is made up of planning, acting, observing, and reflecting. And I think whenever I'm trying to talk about something which is new to me, I think it's always good to try and explain it to the audience because it might be new to you as well. So I found this really interesting diagram, which basically just explains the model. So it's kind of like you're going through this spiral of different phases where you plan your intervention or your training in this case, you act on that and you observe it, you reflect, and then you change your plan. So it's kind of an idea of maybe continuous improvement where you're constantly reflecting on what's gone well, what hasn't gone well. You're able to then revise your plan in this kind of spiral motion to be able to act and observe and reflect and improve it time after time. And I'll share some insight that I gathered from the paper about how this model worked really, really well in this particular case. The other thing that the authors point out is that it was really important to have a framework to base these conversations during the ward rounds. So they developed this really interesting acronym, SALT, which is the framework they would hang the discussions on. So this is quite focused for the particular patient population that they were dealing with. Again, just gathering some information from my research. Lots of challenges around, screening of viral infections in paediatric patients. So screening was seen to be a really important thing. So that's the S. The assessment of new symptoms, lab results as well. So making sure that if tests had been sent to the lab, looking at virology, that those results could be reviewed and that the people were getting the right treatment, the correct antibiotics. And then also kind of how does that follow through into the IPC precautions. So I thought this was a really good way of trying to build in some core components of kind of IPC assessment as part of our ward round in that framework. So this is their kind of assessment tool they use to support those structured discussions. So onto their results, and these really, really surprised me, to be honest. So these are the pre and post questionnaires. And I don't expect you to be able to go through and look at the different categories, but they're talking about things like admission screens, patient environment, isolation precautions, and the post is green and the pre is blue. And I think you can see there's quite a lot of variability. You probably expect that post the intervention of these ward rounds and these IPC practitioners being present to support the nurse in charge and deal with those conversations, you'd expect, I would say, a bigger increase. But we didn't always see that. So we saw some increases on, where to find IPC information, for example, some kind of moderate increases on the patient environment and safe IPC practices, but some of the actual responses decreased. Now, the authors do talk about this as a limitation in the paper. They didn't have very many questionnaires handed out. And because the questionnaires are anonymous, they weren't able to understand if the people who'd actually taken part in the intervention were pre and post were covering both ends, if that makes sense. So they don't know if the same person did the pre and the post, or they just did the pre. So I think this is maybe room for improvement where they can ensure that they were perhaps handing the question out after the ward round to the person who the intervention took place. But we all know how difficult it is to try and get feedback in a busy environment. So some surprising findings here. The other element around some of the results in this paper was the reflective journal, which was kept by the IPC educator. And there's some thematic analysis done after that. And these are the themes that were identified. So welcoming, education provided, areas for improvement or difficulties, and feedback from the nurse in charge as well. And it's really actually refreshing to see that welcoming was a theme, because I think often IPC can be perceived as a bit of an enemy, and the police. And again, Martin on his podcast that I listened to was saying that maybe IPC through this approach are looked as firefighters. So, they're not coming to stamp authority and say you must do this and you must do that, but actually they're there to help you put out the fire and assist you and give you advice on how you prevent it happening again. So I thought that was a really nice analogy. The key one here really is that education was provided. So I think this is a real good proof of concept that doing this process, via a ward round and providing education was really, really shining through. And as well, identifying areas for improvement and where staff have difficulties was also a challenge. And finally, the authors talk about feedback as well from nurses in charge. And I think I'll talk about that in my next slide, because some of the feedback was actually really, really positive. So just to kind of delve into the results a little bit deeper before I go on to what this means for IPC and our discussion, over time, the number of educational interventions that they put in place decreased. So again, I think this is a positive, because over time, I think that people are probably learning more and understanding more about how IPC applies to them in their patient cohort, and you're regularly seeing the IPC team, so you're able to kind of build your confidence about how you're dealing with those patients. Lots of different educational topics were discussed. It also allowed this two-way communication, so it allowed for the staff to be able to ask questions, and even suggest changes in educational practices. Valuable insight from frontline staff about barriers, which we've kind of talked about, and opportunities for improvement. So I think this really feeds nicely into some of the stuff that Jon talked about, is that we think that we know how to educate, and we talk about human behavior, and we've got what we need to get across from an IP's perspective, but are we listening to our frontline staff about how we could make it better? And are we understanding, the barriers to them, providing IPC safe care? This is a really good way to be able to understand that in more detail. And one of the feedback forms mentioned the idea of comparing this training to research training and calling it just-in-time training, which was seen as a real positive, because it was, talking about how this is really useful information delivered during, a requirement in real time, and a positive comparison to other training experiences that have been had. And again, the education information is relevant to the patients being cared for. IPC is so broad, and I think sometimes we're asking a lot of our staff to apply a lot of our IPC principles to a dynamic, patient population. We can't expect all of our healthcare professionals to be experts. That's our role as IPC practitioners. But how can we ensure that, through processes like this, we're giving them confidence to apply in a real world setting information which is relevant for their patients and to improve patient safety. Some of the strengths and the limitations of the paper. So there's obviously a very small pool of participants, which means that the study might not be generalizable. It's also done over a short period of time and only carried about one IPC educator. I think these are limitations, but I think also the paper sets a really good starting point for applying this in a wider setting. So I think this is a great start. It's a really, really interesting approach. And I think that the next steps, which I'll talk about in the next stage, are talking a little bit more about how you apply a wonderful principle to a much bigger environment. So to kind of conclude, I think that this shows that integrating IPC into ward rounds shows promise, builds relationships, it allows adaptability, because you can talk about the challenges that people are facing on that day in the real world and the problems that you might be facing or the barriers from a particular patient or a particular case. It allows two-way communication as well. So it allows us to understand what those barriers are, or understand, where the challenges are, and adapt maybe our learning, or our delivery of education, and how we talk and engage with healthcare professionals. So in terms of further work, they talk about in the paper having a more robust and larger scale study to confirm these results and make them generalizable. Talking about as well, seeing if that makes an actual impact on patient outcomes. So, does it reduce transmission events because we're talking about putting the right contact precautions or isolation precautions in place? And also giving opportunities to optimize how IPC education is delivered, as well as the theories that go with it as well. So kind of lots of really positive elements from this paper about how it was a really valuable tool, and what it could potentially offer in the future with some further work. Okay, I'm going to stop sharing there, and thanks for listening, and I'll pass back to Kerry and Heather.
Thanks so much, Phil, and always expertly summarised and some good reflections already. And actually, some of the chat was really nice to see. I think some people who were saying there we've been utilising that approach of using ward rounds for education. I think more of a opportunistic sort of flavour, that you happen to be going around and seeing patients, and will also take the opportunities from education at the same time. Seems to be sort of through the chat. But interestingly, Sheila says, did the education change practice though? That was a question that she'd wanted to put you on the spot there, Phil.
It's always
how you
difficult
measure
to
that, isn't it? How do you
yeah
measure the impact of that? Is always difficult,
yeah
isn't it?
I think so. One of the measures they had was the number of educational interventions, and the fact that that decreased over time. I suggest to me that it did actually start to change practice. They don't give any details about the specific IPC practices that it did change, but I think it's probably a result of, a building of confidence, a building of a relationship, and kind of hopefully changing IPC practice in that way as people become more confident, and more willing to talk to IPC about, the challenges and barriers as they build those relationships over time.
I think one of the other things that's really important about this type of study and this approach to education in practice is that it does what you've just said, Phil. It creates a relationship between clinicians and infection prevention and control teams and practitioners, and it becomes easier to ask what people think are the risky questions or the dumb questions, or I don't understand. So it actually becomes much easier to overcome some of those myths and misunderstandings, if you like, because staff do feel actually they're here to help us understand how to do this better.
Yeah, I agree with that. I think it's all about that relationship, and the last thing you want is an IPC team that's only ever seen when there's an outbreak. And I'm sorry, I'm going to have to disagree with Martin. A firefighter, you only ever want to see a firefighter when there's a fire. I want to see an IPC practitioner all the time. So I think if we're going to make an analogy, I want to be a coach, some kind of high performance coach. I don't want to be a teacher because that's too didactic. I definitely don't want to be a police officer, because that's not the sort of relationship we have. So I think getting into that coaching mindset and help and guiding people towards performance, that's where I think we need to place ourselves as a service.
I think it's also a real we have a very, very good network still of ward-based, if you like, champions, or whatever we'd like to call link nurses, link practitioners. And I think this is this could be a real win-win in terms of how we use our link practitioners to sort of support this type of I think it is sort of just in time training education. It's opportunistic. It's looking at what's going on and where can we do things better.
Yeah, I think that's a really good point about link practitioners. I think, getting into the study, I was worried about how they would kind of improve that or make it more generalizable in other areas. But I think that's where there's a real role for the link practitioners to kind of be, and I guess that's what you want from your link practitioners. They want to be an approachable, somebody who has that additional bit of experience and expertise to be able to support at the right time. And I'd love the idea of, building a kind of link practitioner into the ward round, because I think that would just build such a great relationship and continuity. So that's a great point, Heather.
I think it aligns a little bit to what Claire and Claire work in the Southwest as well. And I know Claire's made this point before to myself about the challenge in infection prevention should be to sort of integrate to fundamentals of care and not just an add-on. So I think that aligns nicely with that. Actually, if you're doing a ward round, that it's always IPC is consistently thought about, and it's part of that sort of everyday kind of assessment of patients and what we do, rather than, oh, we must also now think about infection prevention and control, and it becomes part of patient safety. And including explaining why, not just what should be done, because it was an interesting reflection. I think someone mentioned that when senior nurses, I think they were saying back in the day, not to quote somebody, I found older nurses, what someone said, I remember when we had to follow the rules, it was not, you just had to do it. You were and whether that has something that's been lost through a sense of accountability. I don't know if just say that kind of falls in that police sort of sensibility, doesn't it? If you just say do as I say, might not always, it doesn't really land particularly well in my experience, but I get the point.
I think the issue of accountability is really important, but it has to be something that people feel for themselves. We can't police accountability, and I think one way of doing that is actually to be this interactive approach to education, an interactive approach to improving practice, observing people's behaviour and trying to work through some of the myths, barriers, enhancers, because you also have really good practice. I think we always focus on poor practice, and we have some great practice that can be used to, if you like, to use Jon's word, coach how others might mirror that. I think that's really important.
Can I throw in something that might be slightly controversial? So, shoot me down. But do we want to be doing ward rounds by IPC practitioners, or do we want existing ward rounds by clinical teams to be really meaningfully including IPC, so that the clinical teams are then identifying the issues and then role modeling the behaviors? Because there's so much. I've noticed a comment in the chat that somebody's been doing it for years and nobody's following my lead. I'm the only one that's bare below the elbow. That may be true if you're kind of external to the team, but if this is the sort of clinical leaders of the team, and the leaders in the ward environment making those leading by example, that may be even more powerful. So yeah,
I definitely would agree with that, Jon.
I suppose that picks up the point about having the link practitioners as part of that, because they are there, they're part of the team. That's how we would like it to work. I think sometimes having the experts as well is a useful thing to do. I suppose my curveball is, why waste time on mandatory training? Because I don't think it benefits anyone. It's a tick box exercise. It means that I suspect no one really learns anything from it. They go through e-learning, getting it right because they got it right last year, and they don't learn anything. It's resource intensive, and I don't think anyone can demonstrate that it actually helps. And I'd much rather those resources were focused elsewhere. So that's a shoot me down moment, Jon. But I'm sort of, I don't believe mandatory training achieves anything other than we've done some training and we don't know whether it works or not.
Yeah, I think I agree with that, Heather. I think, a lot of the time it is a tick box exercise. And I agree with you as well, Jon. But I think that's kind of optimal future state. So I think this is probably a really good intervention about thinking about how we can educate and support teams differently. But I think we've solved the problem. I think the link practitioner is the key, really, to kind of unlocking how as you put it, Jon, the experience in the clinical teams is upskilled over time, and we support good IPC practice.
Interesting for all being controversial about changing practices, about, I guess, hand hygiene auditing is something I think, Jon, you reflected on, whether we should be capturing behaviours and the insights as to why people are choosing or not choosing to perform hand hygiene. And I think that's a really really something that'd be really insightful to find out, rather than it just being you know, this is our compliance, it's this percentage. It'd be interesting to, you know, present to our infection control committees or equivalents to say, and this is what we found out as to what is, you know, leading to some of these behaviours in these areas. And is it environmental? Is actually we just don't have the jelly in the right places, or is it a motivation of the individual? So yeah, maybe that's a challenge to myself, or maybe my areas, to maybe look at how we be a bit more holistic in our approach to that type of auditing.
There's
And
if I can,
sorry,
Kerry,
Phil.
sorry,
Yeah,
yeah,
please
there's a
jump in.
fantastic comment in the chat here from Alta. It says this year we joined handover in the mornings and did on-the-spot training on IPC related to each patient. This was effective and practical, and we got the day and the night shift. Isn't that a great idea?
Mm.
And I think Abigail makes a really nice point as well about sustaining change is vital. Most interventions will change behaviour initially, but then as time passes and the level of scrutiny fades, so does our behaviour change. So yeah, I think that's a really important point to say, that we can sometimes do a bit one-hit wonders, don't we? I feel like I've done that in my past with interventions, and then, you know, we expect the behaviours to be sustained, and actually what people are doing and why they're doing it changes. So we have to keep up, don't we?
I think
So here's a good quote from I think it was Martin or somebody in the Martin ilk who said he or she who changes their behaviour against their will is of their own opinion still. So we have to win hearts and minds to achieve meaningful kind of long-term behaviour change. Otherwise, people will just do it while you're looking.
I think Penny makes quite a good point about the fact that mandatory training online is not useful, but they've had some very good feedback on their face-to-face training. And I think that's a little bit like the intervention we've just discussed, which is, you know, if people are in a room and can ask things and you use innovative approaches to mandatory training, then it no longer becomes mandatory in some ways. It's sort of a bit more creative than you know, the things that have to be done.
And I think Pat's asking about the IPC escape room. It sounds like a fun, interesting thing, because I assume you have to be able to tackle the challenges of the room in order to get out of it. And I suspect it's very IPC focused. So, so yeah, hopefully, Pat, maybe it's get in touch with colleagues in Beverley to find out how to do an escape room for IPC.
I'm sure it's
a focused one as well.
A simulation exercise.
Yes, I think so. Well, that's fabulous. It sounds like there's lots of fantastic stuff that's already happening, and it just reinforces, isn't it, Heather, about why it's so important to publish some of this fantastic work.
You know,
that you're
absolutely. Even a call out through IPS for people who've got educational innovations, and you guys getting together to write a commentary about what you do, how you do it, the evidence you might have for whether or not it works in certain ways is really important. I think, you know, I like to think about research with a big R, but also research with a small r as well, which is about how we question what we do in practice and seek practical and evidence-based answers for, and how we evaluate it. You know, evaluation is really, really important. And so, you know, there clearly are some great ideas out there. So, you know, use this as an opportunity to get together and, you know, think about how you might write some of that up. If not for a journal, then, you know, also just for us in the society to, you know, perhaps bring that together as part of a conference presentation or whatever.
Absolutely. Well, a lovely note to finish on from our point of view. And I'm going to pass on to Phil, who's just going to give some insights to the next webinar.
Yeah, thanks. Big thank you to Kerry and Heather for leading us through that discussion, and thank you to all for everybody who was involved, because that is probably one of the most interactive discussions that we've had since we've launched IPC Partners, and a big thank you to IPS for their partnership as well. So please take your smartphones out, because I'm going to flash up 2, 3, 4, maybe QR codes. We've got a really new, exciting initiative that Jon and I are both really, really proud of. We've developed a series of insight webinars. So we're going to be moving away slightly from the journal club format. We'll still run journal clubs, but webinars are basically taking the information on a certain topic and going into a bit more depth with world leading, and I really do mean world leading without sounding too promotional, IPC experts. So we've got a series of 12 planned for next year, one every month, and our first one is in January. And Arej will be talking about can Alzheimer, Auris, the infection control challenges in Kuwait. So there's a QR code to register for that one. This is our next journal club, which is our last one before Christmas, that Jon will be leading. So this is an economic evaluation of enhanced cleaning and disinfection of shared medical equipment. I'm really looking forward to this one because it's a build from the CLEAN study, which showed that cleaning shared medical equipment for 3 hours a week basically reduced infection rates. So please do scan the QR code to be able to register for that. And then you can see all of our previous recordings on our YouTube channel there as well. And I really do encourage you to share it with your teams, with your colleagues. It's free. Anybody can listen and anybody can get involved in the wonderful kind of insight and discussions that we're sharing during these conversations. So I think that is us. So a big thank you again to Heather and Kerry, excuse me, and Jon, of course, as well. And we look forward to see you on future journal clubs and webinars. Take care.